In the first part, I'll talk about stroke in neonates. Perinatal arterial ischemic stroke is defined as an ischemic stroke that occurs between 28 weeks of gestation and 7 days of life. But most often, it's thought to occur before the first 72 hours of postnatal life, so either intrapartum or shortly postpartum. And it's actually quite common. It occurs in as many as 1 in 2,500 live births, which is approximately the same incidence as arterial embolic stroke in older adults. There are a number of risk factors, both from the maternal side, the fetal side, and risk factors that complicate the process of delivery. From the maternal side, the risk is elevated in mothers who have a history of infertility, mothers who are prima paris, that is, this is their first pregnancy and delivery, if there's been oligohydramnios or prolonged rupture of membranes, preeclampsia, infection, diabetes, antiphospholipid antibodies, and certain drugs that are prothrombotic. From the fetal side, the risk can be elevated by inherited prothrombotic states, cardiac defects, which predispose to shunting, and polycythemia, which increases blood viscosity. And risk factors around the process of delivery include birth trauma, asphyxia, dehydration, hypotension, and infection, such as chorioamnionitis, as well as after delivery, the placement of intravascular umbilical catheters. The most common presentation of perinatal arterial ischemic stroke is focal motor seizures, which begin very early in life, typically within the first 3 days of life, but even as early as the first 12 hours. Infants with stroke may also present with hypotonia, apnea, or encephalopathy. Occasionally, perhaps in as many as 50% of cases, the stroke is silent in the perinatal period or unrecognized and only comes to light at around 4 to 6 months of age when children develop early handedness, seizures, or obvious developmental delays. And in some cases, when strokes don't affect the motor cortex, they may present even later with seizures or developmental delays. When a stroke is suspected in the neonatal period, the modality of choice for imaging is magnetic resonance imaging. Diffusion-weighted imaging can detect an ischemic injury within 24 hours of onset. If there's a history of neck trauma, such as in a traumatic delivery, MR angiography might also be indicated. CT is not often used as a diagnostic modality for perinatal stroke. It's not sensitive for early stroke, and we try to avoid exposing infants to radiation. So for that reason, we tend to avoid CT. If MRI is not available, in some cases, cranial ultrasound may be able to confirm the diagnosis. It's not sensitive for ischemic injury, although sometimes you can see hyperechoic regions in the areas affected. But most likely, the most likely tip-off for stroke on a cranial ultrasound would be a unilateral decrease in flow velocity within the middle cerebral artery. Most strokes in the perinatal period do affect the MCA distribution. We do a limited workup to try to detect the cause of a perinatal arterial ischemic stroke. Laboratory tests are often useful to determine whether there's polycythemia, for example. In recent years, we've moved away from doing a full hypercoagulability workup in neonates with stroke. But if there's evidence of diffuse thrombosis, we might look for evidence of a severe hypercoagulable state, such as protein C or S deficiency or antithrombin 3 deficiency. An echocardiogram is often indicated to look for congenital heart defects or intramural thrombi, which would warrant anticoagulation. If there are umbilical, arterial, or venous catheters in place, it's reasonable to do a Doppler ultrasound to look for thrombosis of the umbilical vein or portal vein. And if it's possible, examining the placenta histologically can also help to understand the origin of perinatal arterial ischemic stroke. You may see evidence of infection or thrombosis within the placenta. This is an example of an MRI in a 2-day-old who presented with focal motor seizures on the first day of life. So we have two axial slices from the MRI, diffusion weighted image and an apparent diffusion coefficient. And you can see that there's evidence of acute ischemia in the distribution of the right and middle cerebral artery. Bright region on diffusion weighted imaging, which corresponds to a dark region on the apparent diffusion coefficient map. In this case, we also did magnetic resonance angiography, and what you can see is that there is an occlusion in the anterior branch of the right middle cerebral artery, which corresponds to the distribution of this stroke. Sometimes, as I mentioned, perinatal arterial ischemic stroke does not come to light until much later when infants and children present with seizures, developmental delays, or especially evidence of early lateralization. So typically, handedness does not develop in children until at least about 18 months of life. So if you have a 6-month-old or a 1-year-old who shows a strong preference for one hand or the other, that's suspicious for a focal injury in the perinatal period. This is a case from Ecuador who presented with early handedness and seizures at 17 months of life. A CT was acquired in this case, and it shows the sequelae of old injury, probably in the perinatal period, including encephalomalacia, atrophy, and dilation of the adjacent anterior portion of the lateral ventricle, probably due to volume loss in the left frontal lobe. This is an MR image of another child with a history of perinatal arterial ischemic stroke or presumed perinatal arterial ischemic stroke. What you can see again is atrophy of the right hemisphere with encephalomalacia, and there's often an overlying hypertrophy of the calvarium, which is called the Dyke-Davidoff mass. When infants present in the perinatal period with arterial ischemic stroke, often the first line of therapy is neuroprotection. So you want to make sure that they don't develop fevers, hypoglycemia or hyperglycemia, hypotension, and if there are seizures, you would treat the seizures with anticonvulsant medications. As dehydration is a risk factor, you want to make sure that the infant does not become further dehydrated or that the volume status is replete. Anticoagulation is not often used in perinatal arterial ischemic stroke, but there are certain selected cases where it's reasonable. For example, if there's an intracardiac defect or thrombus, and you therefore suspect that the stroke is of cardioembolic etiology, it may be reasonable to anticoagulate. Or in cases of severe thrombophilia, such as purpura-fulminans due to protein C or protein S deficiency, where there are multiple emboli, in that case, anticoagulation is indicated as well. Most of these children do survive into adulthood, and very rarely do they have recurrence of stroke. Only in cases, in the latter cases I mentioned of cardiac defect and severe hypercoagulable state, there is sometimes recurrence. But in the vast majority of cases, the stroke is limited to the perinatal period and does not recur in childhood. However, it's not a benign disease. Most children do have some neurologic disability, the most common of which is hemiplegic cerebral palsy, or paralysis of one side of the body. Many of these children also develop epilepsy later in life, can present as early as around 6 months of age and as late as the teenage years or perhaps later. And often these children have developmental delays and school difficulty. So recognizing the disorder is important to counseling the parents and the child about what to expect and what they might look out for as the child develops. It's also helpful in arranging for early therapies. I'm going to move on to another cause of stroke in neonates, neonatal venous sinus thrombosis. This is much rarer than perinatal arterial ischemic stroke, but it does account for most of the sinus thrombosis that we see in children. It's also a common cause of intraventricular hemorrhage seen at term infants, which is distinct from intraventricular hemorrhage in the preterm infant caused by rupture of the germinal matrix vessels. Typically, in neonates with sinus thrombosis, they develop within the first week of life encephalopathy, seizures, poor feeding, failure to thrive. The risk factors are infection, dehydration, and anemia. So all of these risk factors that contribute to a relative prothrombotic state. This can be evaluated with cranial ultrasound. Often you'll see a hemorrhage that's associated with sinus thrombosis. And you can use Doppler as well to interrogate flow within the venous sinuses, especially the sagittal sinus, which is often very accessible to Doppler ultrasound. But you can also look at flow in the deep veins and some of the other sinuses. If available, magnetic resonance imaging can be a very useful modality. You can visualize thrombus, both acute thrombus and subacute thrombus, based on the signal characteristics. With susceptibility weighted imaging, you can see evidence of hemorrhage or, again, thrombosis within vessels. Magnetic resonance venography can be used to confirm venous occlusion, but often it's not necessary. This is an example of cranial ultrasound and MRI images from a one-day-old who presented with seizures. So on the ultrasound, you can see that there's hemorrhage within the lateral ventricles, which is causing ventricular dilatation and hydrocephalus. On the T2 weighted MRI, you can see this hypointense linear lesion, which corresponds to thrombus of the deep vein. And this is seen as well in the T2 star susceptibility weighted imaging, where there's some blooming artifact around the susceptibility, around the region of increased susceptibility. When infants present with venous sinus thrombosis, the mainstay of treatment is dehydration and treatment of infection. Anticoagulation is sometimes used, but it's controversial in neonates. Some providers do prefer it to prevent propagation of the thrombus, even in the presence of hemorrhage. And if there are neurologic sequelae, it's important to treat these. So for example, seizures should be treated. And again, as in the case of perinatal arterial ischemic stroke, it should be recognized that these infants are at high risk of developmental delays and cerebral palsy. So it's important to counsel the parents that these may occur and, when appropriate, to arrange early therapy. Finally, I'll talk a little bit about hemorrhagic stroke in the neonatal period. There's often some bleeding seen in the neonatal brain after a vaginal delivery due to the natural minor trauma that occurs in birth. But it's actually quite rare for neonates to present, term neonates to present with symptomatic hemorrhage. It occurs in about 6 in 100,000 live births. And typically, as in the case of arterial ischemic stroke and sinus thrombosis, it presents with encephalopathy or seizures. A major risk factor is thrombocytopenia, which in the neonatal period can often be alloimmune. Neonates can also have vascular malformations, such as cavernous malformations with bleed. Collagenopathies, particularly collagen 4A1. And use of some maternal medications is associated with hemorrhagic stroke in the neonatal period, particularly salicylates, anticoagulants such as warfarin, and anticonvulsants, particularly phenytoin and phenobarbital. It's most easily evaluated with cranial ultrasound, which will show hemorrhage that is symptomatic. It may not show smaller asymptomatic hemorrhages. And the diagnosis can be confirmed by magnetic resonance imaging, as with venous sinus thrombosis, as we saw previously. The bleeds will be highlighted by T2 star or susceptibility weighted imaging. And if there's access to magnetic resonance imaging, it's often helpful to do angiography or venography to evaluate for malformation or thrombosis. From the laboratory side, we do check platelet count and anticoagulation studies, and we would correct thrombocytopenia or a coagulation abnormalities when appropriate. This is an example of a hemorrhage in a 2-day-old who presented with refractory seizures. So on the cranial transfontanelle ultrasound, you can see a large hyperechoic area in the parietal lobe. And this is confirmed on MR imaging. So what you see again is a large parietal hemorrhage with blood products and evidence of surrounding ischemia. As I mentioned, it's important to correct underlying coagulopathies or platelet dysfunction. An extra dose of vitamin K is often appropriate in these cases. As with other brain injury in the neonatal period, we utilize standard neuroprotective strategies, normothermia, normoglycemia, normotension, control of seizures. Occasionally, if the intracranial pressure is increased beyond the capacity of the sutures and fontanelle to accommodate, surgical evacuation may be indicated, or you may try to decompress with an external ventricular drain, particularly in the case of intraventricular hemorrhage. Thank you for your attention.